Hello, my name is Cindy Kraft, and with me today is Dee Cornetti. We're going to be continuing our conversation around things related to everyone's favorite topic, documentation. Our goal, as we expressed in part one, is not to teach people how to be therapists or nurses. This is not a clinically oriented conversation, but a very important contextual one, because when push comes to shove, documentation is the way we communicate our skill, that our services are reasonable and necessary, and that we have met the requirement of any and all related third-party payers. So it is something that has to be integrated into how we approach care. Not necessarily going to delude ourselves that people are going to fall in love with it and say that it's the favorite part of what they do on any given day, but we are also trying to demystify it. In part one, we spent a considerable amount of time trying to break down skilled, reasonable, and necessary to give us a little bit of a fresh perspective about what that actually means, because they've gotten a lot of baggage, they've gotten a lot of things added in relation to, well, I think it means that, or especially when we've seen ourselves in denial situations, sometimes we interpret the denial incorrectly with things like, well, it's got to be because the therapist, had the patient walk too far, and if you walk too far, you're not homebound. We wanted to break those pieces apart and then try to rebuild it in relation to, yes, it's important to understand skilled, reasonable, and necessary, but we got to go deeper, and very specifically in relation to the provision of services in the home. That being said, we want to dissect a bit the conditions of participation, really focusing on two key areas, the care coordination aspect and this whole idea of patient-centeredness. And I think that if we can take a moment and just set aside the idea that this is yet another rules conversation and nobody really wants to talk about rules, we want to talk about patients, that is what we're going to talk about, is patients. The issue is, how do we ensure that the care we're documenting, the plans we're developing, do meet these expectations? And I think that these are expectations, at least as we outline them in the beginning part of our session together, really can resonate differently with us as clinicians than maybe some other regulations have in the past. As we said in part one, we welcome your questions and feedback throughout the presentation. In order to do that, you need to type that into the Q&A box on your screen, not the chat box, the Q&A box. Those of you listening to the recorded version, rest assured you can still ask your questions. You just need to do so via the email addresses at the end of your handout, which are also at the end of this presentation. So please feel free to fire away with questions related to this particular topic. We are happy to integrate them as we go along. And if that doesn't quite fit, we will capture them on the very end of the presentation to make sure we have addressed them all. So please feel free to fire away. You don't have to wait for a certain signal or instruction to ask us a question. All right, let's get to content. When we start talking about care planning and coordination, I think that the picture Dee picked and put over on the right side is very appropriate. We talk about patient-centered, but by the time we slug our way through our electronic medical record and then this meeting we have to go to and this other thing we have to do and then we got to write it all down, it can very often make the whole thing feel like it's actually more about paper-centered care. A little bit tongue-in-cheek, but very much realistic about how many of us approach this issue. However, we have to understand that expectations are what they are, and it's imperative that no matter what setting we work in, we do take the time periodically to read the regulations for ourselves. Yes, I know, they're not super fun reading like recommended poolside, but I've seen a lot of people over my 20-plus years in home care end up in situations where they swear they know what this rule is. They just can't find it. Where's this rule that says this? Something they've known for years, held near and dear to their heart is the rule, and then when they go to find it, they can't find it. They look in all the appropriate places and yet cannot find any verbiage that matches what they're insisting is a rule that was taught to them by someone who said this is what you have to do. We unearth a lot of the, yeah, that may have been a good idea. It may have been an agency policy. It may have been something somebody heard at a webinar or a course, but the only real rules exist in regulatory documents, and if it's not there, it's not a regulation, which is why we provide here the link to the final conditions of participation, and those were a long time coming for home health. So that link is there. We encourage you to check those resources, to look at those resources, and to help integrate them into how you are approaching and documenting patient care. Finally, we have the final interpretive guidelines. Those are a little bit delayed. We got the final version of the CoPs and said, yep, January 1, you go live. But, the interpretive guidelines piece lagged a little bit. We were dealing with a draft version for more than a couple of months. Why do they matter? Well, they're technically not regulation, but they are what's issued to our beloved surveyors to help them better understand what to look for when they come to do surveys. It's a unique opportunity to get a little bit of a peek behind the curtain as to what are the checkers being told to look for and what would they give as examples and kind of how do we, because that can be very helpful. Because you read the regulation, and there it states certain things, but then how it's executed, how it's interpreted can get a little bit subjective. And so our ability to use resources like the final version of the interpretive guidelines, again, I'm sure some of you that have looked at them may have issue with a few of them and say, well, I don't really like this part, or why did they do? Yeah, you know what? We can debate that ad nauseum. The reality is it is what it is. And so we need to make sure that we are understanding them and incorporating them appropriately. But quick history lesson, why did they change? In home care, we're all very comfortable with it's going to change. Everything changes like all the time. Sometimes it feels like it's changing day to day in terms of what you need to do, what you have to take care of, what's coming down the pipeline, a new OASIS, updates to coding, a potentially new payment model, all of this change. We get very used to this to a certain extent, either used to it or jaded. I'm not quite sure. It may vary day to day. But our conditions of participation are basic requirements that have to be met to participate in the Medicare Part A home health benefit sat there for over 20 years with no changes. Changes were discussed, deadlines were missed, things were not able to be moved through the process in Washington to get them to where they needed to be, and they sat there for a very long time, to the point where it was becoming painfully obvious that the care delivery in the home had changed and kind of had outstripped what these principles were from 20 years ago. So it was a rare situation where getting these changes, people wanted these changes. It was like, seriously, how can we keep getting surveyed under old rules that don't really make sense the way we deliver care now? So what were those principles behind it? And this is where, again, as clinicians, if we just read what these principles are, they do resonate with why you get up every day and go to work. We do care about patients. We want to see a more continuous, integrated system. This whole everybody's kind of on their own little island and people don't know what's going on and how are we really on the same page. We want to see a better system. We want to see a patient-centered approach that is truly interdisciplinary, that is not here's the duties of the nurse, here's the duties of the therapist, and looking at those as lists from the old conditions of participation, it was like, what? One reads with all this specificity stuff in it, and then you look at the therapy one and go, does anybody talk to therapists? This doesn't even really hit what we do or how we teach or how we it kind of read like we don't really teach and we don't really manage patients. Apparently we just walk them around a lot if we're PTs and then get them in and out of the shower. But we want to recognize we all have a contribution to make, to get away from what felt to many like just a ridiculous focus on administrative type stuff. I mean, come on, you all know when you were survey prep was like this big boot camp of dragging out policy manuals. And did you know which policy covered which thing? And did we have all our I's dotted and our T's crossed? And it felt like, what were we actually trying to accomplish? And we know that we all are committed to safeguarding patients' rights. We do not want our patients to have them be taken advantage of, to have their property messed with, to not be active participants in their care. These are things as clinicians that make sense to us. The change in focus was to stop a model that just seemed to have these minimal requirements, like as long as you had these certain pieces in place, well, okay, then you were safe with respect to the survey. This model is really trying to get us to focus on quality as an active, integrated process. It's not check the box, look, that makes me a good agency. There are times where I'm looking at our processes and things don't work, but we're looking at them because we want to improve them, not trying to camouflage them so the surveyor doesn't find them and we just get all the boxes checked. But how are we really looking at how we provide care with a critical eye that says, where are our opportunities to do better? How do we really refine our care? And that is an ongoing process, and sometimes it has elements that feel a little trial and error-y. Let's try this, well, that didn't quite go the way we wanted. Let's try this other. It's more of a living, breathing approach to the quality of care and not a checklist issue. And recognizing that sometimes these requirements that we've had in the past, did they really mean we were delivering good care? Did that really mean we were preventing bad outcomes? I mean, let's be honest, as the slide says, there really isn't clear evidence that some of the previous requirements actually meant anything. Again, nobody's saying that they were like terrible, but they were created at a point in time that we had far exceeded. And with technology, with better interdisciplinary management, with a higher acuity of patient coming into our setting than maybe there was 20 years ago, things needed to change. Also, what else drives change? It's not that somebody in your organization went to a class and came home all fired up. It's not, oh my gosh, we better do something now because we got a denial. There are larger initiatives even beyond the COPs that are looking at what are those priorities from the looking at the national quality strategy. There's 6 priorities, and one of the big ones is care coordination, to get rid of fragmentation, to make it more organized, where handoffs are clear, improvement in access. You see the theme. This is not because Dee and I just, like to hear ourselves talk, or we don't think you're listening, so we better say it 10 different ways. We're trying to show you the themes between our own COPs, between this issue of the Healthcare Quality Report, of looking at these national quality priorities. All of this fits together in relation to safer care, getting our patients involved, controlling costs, dealing with these things. This is not meant to be a webinar that does a deep dive on any one of these, but it's really trying to help you see that when we spend the rest of our time together looking at this issue of care planning and care coordination, it's not a one-off. It's not, do I have to sit here long enough so, I was present and then I can just go and do so. It's to get our brains engaged in the sweet spot of patient-centered care. How do we really execute that? Because we've gotten a little lax in our documentation. This whole, patient verbalized understanding, patient return demo, patient agreed with goals, patient agrees with plan of care. Really? Because I have never heard a patient in my 20-plus years as a PT ever look at me and say, I want to be able to ambulate 250 feet with a walker and standby assistance. I want to be able to bathe with supervision. I don't think anybody would say I want to be able to bathe with supervision. What, I want to be watched while I take showers? I don't think that's the words coming out of people's mouths. How do we do a better job? And I think, again, as clinicians, this is something we can sink our teeth into. This is something when we stop resisting this idea and really say, okay, how do I really execute this? Meaningful change. Because I think a lot of times our good intentions around care coordination have really kind of been more of, let's provide updates to other disciplines. It's not necessarily that we are averse to care coordination, but it's kind of hard in home care because of the nature of how we deliver care. We are physically fragmented. We're trying to get cohesive in the approach to care delivery, but we have just the physical challenge of not typically being all with the patient at the same time or in a close enough proximity, like in a facility where we see each other in the hallway, we can get somebody's opinion at lunch, we might walk past it, and just seeing that other person reminds us of something, and we have a great conversation about what to do with this patient from a coordination standpoint. This kind of activity in home care requires a high degree of intentionality, that we are still a coordinated, trying to be less fragmented approach to care. But what does that look like? It's not all being forcibly put in a room to put my initials on the paper to say we talked about this patient. Because very often the case conferences I participate in are everybody kind of just throws their update on the table and everybody else goes, Just don't talk too long because we got to get through X number of patients in here. What we're trying to stress today is how do we take those COPs and embed them philosophically into how we approach this patient care issue. Because here's a quick review. When we take on a patient, the regulations say we have to have a reasonable expectation to meet their needs, their medical, nursing, rehabilitative, and social needs. We must provide an individualized written plan of care. That is a big sticking point when I do reviews, when we see denials, is this idea that this plan of care doesn't look particularly individualized. It looks like we just kind of click a whole bunch of things on our computer and a plan of care spits out the other end. I've talked to many nurses that'll say, they miss handwriting care plans because when you wrote it out by hand, you wrote down what you were going to do. You didn't start writing down everything in the kitchen sink because you didn't want to have to write all that stuff. You focused on what you were going to focus on. And I think a lot of our technology has enabled us to click a bunch of things in a care plan that we either don't necessarily read through anymore, or it sounds interesting, it might be relevant, and suddenly we have a care plan that's 10 pages long. Were we really going to do all that in a 60-day episode of care? This is where less is more and focus is critical. We also have to be able to demonstrate that the physician is involved in the plan of care. Okay? This idea that a physician can just kind of throw the, as we touched on in part one, home care as though that's an order without any sort of input and kind of just do whatever so they don't bother me. No, this is a regulatory requirement issue that we are seeing that the physician is actively engaged. That we're also looking at how are we assuring that we have identified patient needs and factors that could affect their safety over the course of care. So are we demonstrating scheduling considerations with this patient? Are we looking at that? I mean, I understand. We also can't necessarily turn it into an on-demand free-for-all that, we can only go exactly when the patient tells us because we have so many patients that have to be seen and we have geography to cover and all that. But do we have conversations about their preferences? Do we really do pain management during visits? I'm not talking about knocking out the most recent 0 to 10 pain number. Come on, you don't even have to ask them that. They say, hello, I'm a 4. Wow, they got asked so many times they beat me to the question. Boom. That's not pain management. That's writing down a number. Are we really doing something about the number? What about those home safety modifications? Home is safe. Home is unsafe. Home is cluttered. Well, like every room in the house, how cluttered is cluttered? Are we talking need to pick a few things up, or are we talking going to be on the next episode of Hoarders? What specifically for this patient requires some modification here to preserve their safety? And how are we showing clear communication that the patient is involved in this discussion throughout the course of care? And those 4 areas are pieces that we can say, well, okay, whatever. No, when they're mentioned in the regulation like that, they give us hooks to hang our documentation on in relation to, am I demonstrating those things that occur? And if there are things that maybe I haven't necessarily addressed, it's our opportunity to bolster our efforts to ensure that those things that are important to the patient are finding their way into our documentation. Coordination of care needs to talk about patient's needs. And again, we have to be reasonable here. No one is now saying that the patient dictates everything we do. The patient is totally driving the okay, wait a second. Because we understand sometimes our patients may have unrealistic expectations or feel like it's demands that don't fit with the nature of their disease process, that they want certain things that don't make sense or expect certain things. We're not saying that now they tell us what to do. We are the medical professionals. We are expected, as we talked about in part 1, to follow the parameters of our licensure, to speak to the skilled, reasonable, and necessary. But our current documentation, far often than not, looks like we're doing all the discussing and the patient is just agreeing, I guess. How do we assure that they're participating, especially when we're getting into this issue of education? Okay, we do a lot of education amongst the disciplines in home care. You have to. You're not moving in with them. There's a bunch of stuff that they have to be able to manage in between your visits. And there's a lot of hours out of a 60-day episode. Nobody from your agency is actually there. So education is occurring. And the problem is we tend to document education to varying degrees. Sometimes we only put med teaching or caregiver ed. We need to do better there. But what we understand from these COPs is we have to show the response to the training. Did they understand it? How do you know they understood it? I'm telling you right now, I'm on a warpath, and I think we're seeing issues around denials as well by extension of this verbalized understanding and return demo. Verbalized understanding, they repeated back to you what you just said and you're still sitting there. Return demo, yeah, while I'm still sitting here, I just showed you how to do it and you showed it back to me. How do I know you really understood it? Does time need to lapse to see me come back and ask you now to tell me what needs to be done, to show me now after a couple of days have gone? How about we get wild and crazy and have the therapist who's coming in the afternoon ask them about a medication they were just taught on that morning? Collaborating with the nurse, I just taught him about this. I want you to ask him a couple questions. What are his answers? What about that exercise program that I provided to the patient who did all kinds of return demo while I was there? Can they return demo any of it when the nurse comes tomorrow? This is not taking away from individual disciplines. It's using each visit as a way to advance our cause, as it were, in relation to not only patient-centeredness, but how are we ensuring that they are understanding what we're saying and incorporate it? Because we do not take over their care in home care. We are coaches. We are trying to teach people how to manage their own disease process, their own functional limitations. We don't take that over for them. So their ability to understand, their involvement, their engagement is huge. And I know this gets into the, yeah, but we're not supposed to say, when people aren't, they're non-compliant, that's a bad, okay, we're not getting into the semantic issue. I'm not sure we've done the best job possible to engage the patient, to help them understand that I'm not the hospital, I'm not the nursing home. We don't do 24/7 in-person control of your care. You have to make sure you're taking the medication correctly. You need written information in order to help make good decisions. We're partners in this. I'm not bringing the hospital to you. That's not really a partnership. You're really sick. They're trying to get you better, so ultimately you can go home. We're trying to help you manage this longer term. And clear communication about when we're going to come, what they need to take, what kind of treatments helps patients understand their level of involvement. I think we do ourselves a big disservice on the very first visit with, I'm here to take care of you. No, we're not. We're not designed to do that. We're here to make sure they're able to take care of themselves, or they have people around them that can provide the appropriate level of support. So we want to do a knowledge test. We know we like to do these. So I want you to think about this. Which of the following best represents training and education provided to the patient and or the caregiver? So we have response A, nursing provided caregiver ed on medication management and pill box setup. Continued assistance required. B, OT provided patient training and use of long-handled brush and sock aid with status post-lumbar fusion. Patient requires verbal cueing for proper body mechanics when using devices. C, PT provided HEP education. Patient is independent with HEP. Continue PT for strengthening per established plan of care. SD provided swallowing education. Patient and caregiver are independent with verbal instructions. Patient is on a mechanical soft diet. Clearly, education has occurred in all four of these, but which one best represents not only that education was done, what are the specifics around it, why does it take a skilled person to do it? Based on that criteria, the best response we have here is in fact response B. When we look at the other responses, you could extrapolate it's important to manage your medications. It's important to do your swallowing properly. It's important to do exercises. But it didn't give us enough context as to what patient-specific issue was it addressing, why did they need it. In B, we see the OT was providing training in what? Not just ADL management or bathing, use of a long-handled brush and sock aid. Why? Because of a lumbar fusion. That's very specific. What do they need from the OT? Verbal cueing for proper body mechanics when using devices. You can get a visual of what the OT is doing in this situation that really speaks to training specificity that is patient-driven. Again, it is not physically 10 times longer than the other descriptions, but it's getting away from this kind of canned caregiver education, medication teaching, ADL training that we have maybe been allowed to do for years. That it kind of slipped through the radar that, oh yeah, every time PT does it, there has to be an exercise program and they all need to become independent with it. But we're seeing the denials. We're seeing the targeted probe and educate. We're seeing renewed efforts from people like the surveyors saying, this does not look like it takes a level of complexity that warrants a skilled service. And we get mad. We say, that's not fair. You don't understand what I do. No, but they read what we write. And those are the things we have to match up. So with that, Dee, this idea of patient-centeredness is such a strong theme. We need you to spend some time with us helping us better dissect and extrapolate that to something we can actually tangibly ensure is in our documentation going forward.
Sure. And, it's not so much about the concepts, as you've been saying, but that actual application. So I think going through and really walking through that knowledge application exercise, what is the best, is really to try to touch on how do we take this information that we've gathered and how do we care plan and demonstrate that individualization in the record when we document what really is essential. We know we have to write to payment requirements. We know we talked about that in the first webinar. We know we have to talk about eligibility requirements as a criteria for receiving care under the Medicare Part A home health benefit. We also talked about that in the first installment of this webinar series. But this one kind of takes our findings to another level and really requires us to work as an interdisciplinary team, singing off the same sheet of music, focusing in those areas that are specific to our discipline's skill set. And so we're really going to talk about, and hopefully incorporate some examples about how we show this care coordination, this fluency. And so it's really important in the COPs that we reflect that we have coordinated our care, that there is evidence, not just a physical evidence, but a reflection and a utilization of that evidence that is captured in the medical record. Think about those times when you go out to see a patient and they've had a bad day or they've had an adverse effect of a medication or that, and that's well documented by the nurse, but if there's another visit that day, it goes on as if nothing has happened, especially if it's by a therapist, and nothing was ever commented on, right? Or there was a significant statement made by the caregiver or the patient themselves or about their pain, and how is that impacting not just the care that's provided by that point person, but is it something that has to be addressed through communications with the physician, and not only them, the other care team members. And so it's really important to capture that fluency when we have multiple disciplines involved in the house, that there is very clear efforts made and procedures around and behaviors that are demonstrated that that focus around that patient-centered care plan, our overall objectives for this individual, okay, and include the input of the patient and or their representative, right, and their caregivers and family. And so it's extremely important that we utilize all this information to get to the right amount of service or services provided at the right time based on the presentation of that specific beneficiary or patient. And ultimately, I think it's worth stepping back for a second and really tapping into that. Whose responsibility is it? Many times we have clinicians that really do a lot of opening of cases, or they work a per diem shift on the weekend on a regular basis or irregular, or they're mostly the evaluating therapist, but maybe some of the assistants carry out the regular or the more routine, ongoing, more frequent visits for patients. We have to remember at every touch, we have to look at the case, we have to look at the individual, we have to look at all the information that's available to us. And EMRs have done a wonderful job providing us finger point or touch access, at the end of our fingertips, access to extensive and robust information. My question to each and every organization that I talk to about this is, what is it that you expect each clinician to be aware of before they walk in the house, to document while they're in the house, and to report on after they've provided their care in that house. And ultimately, that boils down to not a regulatory issue, not a payer source issue, not a Dee and Cindy. We're roided up, if you will, PTs that are all gung ho in home care, and we're gonna pump you up and get you doing this too. That's not it. It's about your professional licensure. It's about ensuring that you're following your code of ethics and standards of practice, and practicing to the full height and the width and the breadth and the depth of your licensure requirements, regardless of what discipline that is. We still have to attend to all those eligibility and reimbursable service requirements. But when it gets to patient care, I always like to say, is this the way that you would plan care, provide care, and document care and follow up for your own family member, or someone you care about, or a loved one, if that's not your family, right? How would you do that? And so we have to have that standard of putting the patient at the center of care. And ultimately, each and every touch we have really should be about looking at the whole picture and then diving deep into those areas that we can impact that require our skill at that moment, at that visit in time. And so when we talk about essential elements of our documentation, how do we operationalize this? We do it through our documentation. We reflect it. There is no doubt in my mind that 99.9% of the clinicians that go out there do great care. Maybe that's a little bit high, but I'm going to be very optimistic today. I know the majority do. I know well in advance of the majority, or in excess of the majority do. The problem is we as an industry, we as discipline-specific licensed professionals, we don't document very well towards it. And so it becomes extremely important if we look at these requirements that we've talked about: homebound, skilled, reasonable, necessary, clinical judgment, that we covered in the first webinar in this series, that today we really focus on this care coordination and patient-centered care. And I know people want answers. I know you want a checklist, and Cindy says, Dee, I know you got one in you, and I probably do somewhere. But ultimately, it's not about a checklist. It's about understanding those essential elements, those concepts. And so when we break down the components of a care plan, we have to realize that we've built our goals, we've covered a lot, and we've provided the baseline information, included the subjective patient-specific information that must be captured to establish a baseline. In that first series, when we do that initial visit, whether it be the comprehensive start of care or our discipline-specific evaluation, and we've developed those goals. Check. We can check that point off. We're done with that one. But really what we're looking at now, that's not the end of it. Now it's bringing life to that document, right? It's like looking at a play script, where you have actor A says this, actor B says this. Then you got to put them on a fully set stage, and there has to be timing, and there has to be the right emotion, and there has to be the right orchestration in their movements and in the supporting movements and in the way things are provided to tell the story. And so this is where the rest of the care plan becomes extremely important. We want to integrate all the clinical implications of the severity, the complexity, the acuity of this specific patient, their diagnoses, conditions, and diseases and disorders. We want to talk about how it impacts them functionally and restricts their normal activity or their ability to participate. We want to outline what are those evidence-based interventions. What are they specifically, and what must we provide, and what must we train and educate to be provided in our absence because it doesn't require our skills. But still, the selection of them as appropriate is in our skill set. And then we have to establish utilization for frequency and duration that is no more cookie cutter than the original eval. So it gets really hard to have individualized care plans when think back when our interventions are generally gait training, transfer training, bathing, dressing, swallowing, right? Med management, disease process management. They're not specific. It gets very hard to have very individualized utilization outlined when we haven't really captured the details where it lends to decision making, all the clinical implications and the functional implications for this patient in this house. When we write goals that are real generic, like patient will optimize functioning within the 60-day episode, patient will maximize independence. Um, those kind of things, that's very hard of a mark to hit, let alone measure. And it really does not set us up for success in developing individualized care plans. And so we see utilizations that very commonly look like 2-week 9, 1-week 9, right? 3-week 4. And everybody, regardless of their presentation and their unique needs, is kind of generalized. They become very generic in nature. Everybody is, if they were ice cream, they'd be vanilla, and that's just we don't set ourselves up for success. And we certainly don't set up our charts and our care for defensibility. And it certainly doesn't allow us to really be able to identify where we're doing well, where there's room for improvement, to inform our QAPI programs, and to impact our outcomes, let alone our patient satisfaction. And so when we're talking about developing these care plans, I really want to look at it from a therapy perspective, not to leave nursing out. Okay, but because, being a therapist, this is the language, this is the mentality I use. And a lot of times we're really focused on the functionality of how these disease processes, conditions, and disabilities impact a patient's activity and participation. Nursing is going to help manage those signs and symptoms and the daily accountability for these long-term disease processes that are not going to resolve. Right? For minimizing signs and symptoms, for the importance of medication, what their roles are, what to look for if it's not the appropriate medication, right? Adverse effects. They're going to be talking specifically in that disease process realm, or that's a big part of what they do, right? But in therapy, in our assessments, we're looking to tie all their quantified impairments that we mentioned on the last webinar to the functional relevance for that patient. What is it that the patient is now limited in doing? What is the participation? What normal roles and responsibilities can they no longer fulfill because of their current state? And then we select those interventions that are determined by those specific assessment findings and are appropriate to either follow a course of improvement under restorative therapy or stabilization of function under a maintenance course of care. And our utilization of frequency and duration or determination of intensity of services should be based on that. Now, to this point, that service utilization has contributed to payment, but that's going to be going away as far as a payment contributor. But that doesn't mean it's going away as an important component of meeting and improving or stabilizing patients. It's integral that we continue that. And so we have to start making decisions for interventions and utilization based on how we're going to impact this patient's acuity or their severity and how we're going to hopefully reduce their risk. So it's a very purposeful activity that we have kind of, and Cindy, you've said this many times before, we have taken for granted. It's like breathing in and breathing out. We don't really think about it all the time. And I really want to drill down and get to the very basics of it. Really make a concerted effort to build these individualized plans. Really remember that you're utilizing a skill set and don't wash over it, because I think we can do better. If we don't even improve any of our assessment findings, if we don't add any more tests and measures, or maybe just a few, we're going to already do better if our activities surrounding care plan development are purposeful and are interdisciplinary in nature. And that's going to tick a lot of boxes come survey time. That's going to tick a lot of boxes with ADRs and targeted probe and educate potential reviews. That is going to tick a lot of boxes if denials are if we're in the spotlight for denials. That's going to make it a lot easier to defend the case when we can see the evidence of skilled decision making versus cookie cutter care planning. So again, just as a reminder, the best way to capture patient uniqueness is to factor in those interior or internal processes related to the health condition, how it affects body structure and function, how it limits activities, restricts participation, as well as those external factors, those contextual factors, the environment that contributes or is a barrier for this patient, as well as those personal factors, their cognition, their motivation, and their social support or lack thereof. We do this through application and using the terminology and these components of the ICF, or the International Classification of Disability, Wellness, and Health or Functioning. I never get that right, but it's the World Health Organization's ICF biopsychosocial model, where we look at both those internal and those external contributing factors that really individualize this care plan. So let's dig down into it. What are those intrinsic factors? Well, I've outlined it. It's what the disease process is that they're dealing with. What are their knowledge deficits? Where is there a lack in their understanding? Nursing spends a lot of time and has a lot of expertise in this area. But I have things to lend as a therapist when we're talking about diabetic foot care, right? And about use of shoes and protective sensation or LOPS, loss of protective sensation, and prevention of lower extremity amputation and footwear, and the importance of proprioception, kinesthetic awareness on balance. These are important things that I can contribute, although I may not be doing a full-blown diabetic education for a newly diagnosed individual. We also talk a little bit about the functional and the safety relevance. Safety can be a factor of the environment, but can also be a factor of the patient's outlook and their understanding of where their limitations are and their acceptance of that. When we look at extrinsic factors that we need to look at that social support system. We need to look at that physical environment. A lot of times, when we're dealing with individual houses, no two are exactly alike for the most part. They're not decorated alike. The lighting, the floor surface, all those things are not exactly alike. We need to look at how that impacts, either to assist or to hamper the patient's safety and thereby impact their independence. Or their stability, if you will, in maintaining their ability to do these things without incurring harm or being at risk for some hazardous things such as a fall and an injury. We need to look at what equipment, what recommendation. Is there any adjunct services that need to be involved? Okay, and if they are, we need to start to look outside of just what we provide within our agency, within that home. But are there other community or state services that can and should be incorporated as part of the team, in addition to us and the active physicians? This is all something that should be captured, and we should all be aware of it. Now, I'm not saying the PT has to do it on the eval, and the OT has to do it on the eval, and the nurse has to do it on the comprehensive assessment admission, but we should all know what is in play with this person related to these basic intrinsic and extrinsic factors that individualize our patient care. Looking a little bit further at intrinsic, let's talk about what the disease processes. Let's talk about how acute, how severe they are, what comorbidities are impacting care. How are they managing those diseases or not managing those diseases? Looking at knowledge deficits, is it with their current conditions, their current course in the hospital, their post-surgical precautions? I don't know, how to take care of that post-surgical wound, the wound vac device, understanding that, or the IV administration of medications, do they understand that? Or their chemotherapy treatments that they'll be starting? Is it the medications? Where is that deficit? And really be able to hone in on not just medication, a knowledge deficit, but what in particular is the focus? Where are the gaps? And what are the impacts of those gaps? As far as functional or safety, looking at their mobility, looking at their self-care. What is something that this person wants to do, needs to do, used to do? Contributes to their independence, their quality of life that is reasonable for them to do, that is reasonable for them to return doing, or that they need to be stabilized to continue to do into the future. Let's just maybe tick off these boxes as a really good start of what we're focusing on when we build this individualized care plan. Looking at those extrinsic factors, specifically the support system of caregivers. What is their availability and willingness? We've all had that patient who has the most willing family or spouse present, but they're sometimes no better or they're worse off than the patient. Willingness alone is not something we need to jump on. We all know. So we have to say willing and able, and we should talk about what they are willing to do and what they are able to do, an assessment of that, and that ability to meet their needs. And looking at that caregiver strain and how that can impact the patient. You know, I've had patients that, but for the grace of having a very capable and basically a marathon runner of caregiving in their home, you know, it was a slippery slope. And if that person kind of tipped, or that person was under the weather, or that person, God forbid, had an event or an accident or was trying to do too much that they weren't able to do, and they put themselves at risk and they hurt themselves, the ability of the patient themselves to stay in a home environment was tenuous if there wasn't someone else to step in for a period of time. We have to be able to identify those when we see them and capture them, because they are extremely relevant, and they will impact and they will help inform our utilization and our determination of what services are appropriate. Looking at the environment, it's the physical plant, absolutely. How it is set up, how is accessible, but also, you know, looking at footwear, looking at lighting, looking at doorways, looking at equipment that has to go through these areas of the home. What are the mandatory areas of the home that this person has to access? And is it something they're going to be able to get back to doing, or are we going to start to modify the home or look at modification alternatives to make it more accessible at a different level for that patient, because returning to the way I used to do it is no longer viable? And then how does the community become involved? And this is a great opportunity to look at what resources are available to the person. We all get those lists that sit in the house of all the community services and the emergency transport and the non-emergency wheelchair transport and a taxi service, right? And then the senior services or the county services. You know, the people that know this best are medical social workers. And I have never done so well in being part of the care planning team from the minute I evaluate a patient that I find areas of deficiency as when I say, are we bringing a social worker in? That means that that person is going to help us identify what resources are out there available, and not just pick them off the list of in the home folder. Okay, and so being able to maybe look at this slide and the previous slide as a way of saying, have we captured this information somewhere in our collective evaluations, and is it reflected unique to that patient in our individualized care plan that ends up in our 485 that is signed by by the authorizing physician? And are we documenting who is doing what to what areas? You know, obviously, I would expect that the therapist would do something more towards equipment and environmental if those are the areas in their domain. If it's an IV, I'm not messing with that, right? So equipment may fall to the nurse. But disease process management, what is my role in that? What do you need me to reiterate with them? What are the areas of deficit so I can make sure when they touch on what I'm doing as a therapist, Mr. or Mrs. Nurse on my care team, what I can reiterate what is important for them and make sure that they're hearing it from any and all resources. You know, we are all singing from that same sheet of music. And so when we identify those disciplines, maybe we look at these are our areas of expertise, not our lanes, not our silos, but these are our areas of expertise, and the aid can support us across all of these. But we all need to be aware of what's going on if it is a patient-centered care plan. And so that might be a way of starting to say, you focus there, I'll focus here, we'll all come together. Right? You know, just like a builder of a house has to all communicate, we don't expect the carpenter to put in the toilet. We don't expect that. But we got to make sure that the carpenter includes a bathroom in the house so we have a toilet, we have a place to put the toilet, and it doesn't end up on the front porch. All right? These are very important, things that if we really reduce them to the very granular elements, you're probably saying, Dee, you're being silly with some of your examples. But let me tell you, and Cindy, you could chime in if you want, some of the charts I read are our toilet's on the front porch. It's crazy because I think we've lost sight of what is the big picture. What is my area? How do I communicate that with everybody? And how do I have a clear understanding of the big picture of this patient from everybody else on the team? So when we're looking at choosing those interventions, we have to make sure that we have, let's go back to the concept of restorative versus maintenance, whether we're looking for this patient to recover function or optimize and maintain where they are and prevent or slow deterioration or decline, right? And so when we think about the interventions, we may still be working in the same, out of the same pool of choices, right? But we have to do it with an eye to, is this going to help them get better, or are we trying to stabilize them? Because that's going to inform goal setting, that's going to inform utilization decisions, right? As well as the acuity and the severity of that disease process. But one of those elements in and of themselves is not going to do that. And so when we think about it from this perspective, and I'm just kind of rolling it back to you for this because I don't want to spend a lot of time, it's a little bit of a repeat. Remember, look at the characteristics of the patient. In a restorative case, it's usually a fairly acute condition that lands them on our front doorstep, or us on theirs, if you will. There's usually a complexity that requires our care, and there may be complicating factors or comorbidities, and we're looking to manage those symptoms, right? And we're trying to remediate them and facilitate them through that period of recovery. Under maintenance, we're looking at a less acute condition. Maybe it's a recent exacerbation of change, but it usually is a chronic condition that's not going to resolve or heal. Many times we're not just dealing with the complexity of a comorbidity, but multiple ones, as well as some of the sequelae that arise from those conditions. Think diabetes and nephropathy, neuropathy, retinopathy, right? There may be a history of mismanagement or gaps, if you will. Let's try to capture those gaps. Let's try to minimize those gaps this time around. And we're looking not to get them on the road to recovery or facilitate them back to some higher, more independent and safe level, but we're looking at stabilizing their function and reducing this mismanagement going forward. Have we been able to put our finger on that? Have we been able to capture that and reflect that in our documentation? So maybe some questions. I'm a big question person, Sometimes I don't think, well, Dee, what are you trying to say? What question are you trying to answer? Well, when we're looking at outcomes, we always want the ones that are going to positively reflect for the patient, so it affects our CAPs, all right, our patient satisfaction. We want it to positively reflect on our profession. We want it to positively reflect on us and our agency, and we want to see it in our publicly reported outcomes. So think about it this way. What is the patient, right? What do they want to achieve? I always ask patients, if I can do something for you that when we say goodbye, you'd say that was, Dee was so integral in helping me or getting me back to or ensuring that I will be able to remain doing or having or whatever. What is it? And usually patients don't hem and haw. They can give you at least one. I want to be able to walk without this walker. I want to be able to climb the stairs and sleep in my bed and not have to sleep in the recliner at night. I want to be able to get myself showered and dressed. I want to be able to go out with my friends and play bingo, and I can barely get to the car, right? I don't want to use this wheelchair. I want to be able to make dinner on Sunday evenings for my family. That's something I've done, and I live close to my family, and I'm, and frankly, my daughter-in-law doesn't cook very well, right? Or something like that. I don't know. I want to be able to do my own laundry. I don't want to have to rely on people. And I'll say, for what? What don't you want to rely on them for? Let's pick something and see if we can tackle that, and kind of, set those agreements. What knowledge do they need? What ability do they need to get there? What condition needs to be resolved or stabilized to accomplish that goal? Think also in outcomes, what is required to either get them better, right, return to that prior level, or stabilize them to reduce the likelihood of deterioration or decline? what knowledge is needed, what functional ability has to be maintained, what support or equipment would be beneficial and would help this and would, make this possible or support the movement in this direction. I don't think we do a good enough job explaining that to patients, because if we told our patients every time why they were working and making their muscles sore because we were loading them with cuff weights or making them do resistance exercises, but it was going to help them do this again, I think we'd have to put the brakes on them because they'd be overdoing it. And I always tell them, I know you want to get there, but the muscle system is not built for you to get there between today and tomorrow. But I know you wanted to be there yesterday. I gotcha. But if you do too much, it's just as bad as not doing enough, right? I mean, we all know these things. And so if we engage our patients and their family members and we explain why these activities are important and how they're going to support their individual goals and their functional needs and their knowledge deficits so that they can remain in their home, they can continue to function. They don't have to get a frequent flyer card to the hospital or the emergency department. And we're going to try to help them through that to make it different from this point forward. I think you'd absolutely have a lot more willingness, compliance, and eagerness when you knock on the door, because nobody likes to see the therapist, right? We're not their favorite people, but if they know we're the process they go through to get to this other side of functionality. I've never had someone say, I absolutely want to be there, but there's no way I'm going to do this. I think people get that. Okay, and so this might be a great slide to help start those generative discussions with patients and their family member to find out what's really important to them. Cindy, I don't know if you have any comments about that or anything that you want to add at this point. That's kind of like a little soapbox of mine.
Oh, I just want to let that lie because I am very impressed. I'm still stuck on your when you said we were roided up comment. So there's your motivational piece. I think people. No, but in seriousness, that's what we're trying to do. People want a list of just tell me what you want me to write, or tell me what you write so we get out of denials. We do know what to write. I think we just haven't given ourselves permission to do so, and have essentially invalidated the scope, depth, and breadth of what we know and do by making it so simple and so sketchy in the documentation. We allow people to conclude it's not that difficult. I don't know why we're paying you.
Yeah,
and it's unfortunate.
Mm-hmm. For me, every day I want to go out there and I want to make a difference. Maybe I have an excessive need for self-gratification there, or to feel important. But I want to make a difference, and I think I do. But I can't make a difference for everybody if I treat them exactly the same, if I yada, yada, yada through it. And I'm not saying we ever do that with patient care in our interactions. But our documentation says we yada, yada, yada. That's what it does as an industry. And so these might be, if you find you're in, if the light bulb goes off in certain comments that we're making or this discussion that we're having around this webinar presentation and these slides, jump on it, ride that, make it your own, because I think the only person that's going to benefit from it is the patient, and that's important. So let's talk about fluency of documentation and get into some examples before I hand it back over to Cindy. First of all, if we're going to talk about fluency of this documentation, we have to adopt that a bigger care plan, a more extensive one with just silo plus silo plus silo of volumes of generic information is just that. It is more. It is not better. It does not facilitate communication. Let's work on this premise of one beneficiary, one care plan. Let's start with where can we find centralized data that we can all huddle up around. Let's start with the OASIS data set. We know that we capture information on function, on falls, on integumentary, on medications, on depression, nutrition, cognition, environment. And I don't know why the T in support is white, but I'm rolling with it. That must mean something today. We should all know that. I don't care who's responsible for filling it out. We should all know what the findings are and what is being scored on this individual to be able to find our opportunities for improvement in a restorative or recovery course of care, or maintenance, stabilization in a maintenance course of care. So, taking that concept of one beneficiary, one care plan, let's look at one of the biggest outcomes that administration stays up at night about, that worries about, that impacts this organization, that makes you a good bundled payment or alternative payment model partner, and it's hospitalization rates, right? What is causing risk for rehospitalization? Everybody should know that. So let's look at it more detailed in a patient situation. What about if you have a patient that you are admitting who has heart failure, right? And you see the admitting clinician has listed all the rehospitalization risks: smoking, obesity, medications, multiple medications, 2 or 3 hospitalizations, lack of compliance, whatever those elements are. You should know what they are. Okay? And then you have to look at what your role is, because let's face it, with a heart failure patient, there's maybe 3, 4, 5 things that we're going to do as best practice that are important in maintaining somebody at home and making them personally accountable for their own disease process. They need to know about daily weights. Nurses get them set up with or without telemonitoring, explains the reason, the this, the that. Therapists, are you making sure they can get on and there safely to get a valid score? Medication, and it's done every day, right? It's an ADL. Why isn't it done as part of their morning routine? Why aren't we making sure they have the lower extremity strength and the balance to get there? Medication management. Okay, again, typically falls to nurses. But I need to know what medication they're on, the effect that they're going to have on their heart rate, the effect that it's going to have on their response to exercise. And can they get these meds, and can they take these meds? Can they manipulate the bottles? Do they understand? Are they taking it consistent with when they should? We can all support that behavior and get behind it. Dietary restrictions. Again, we think nursing, right? Maybe they'll say you can't be on these foods. These are high in fat, high in salt, not good for your heart. Great. Explain the whole pathophysiology of having high salt, high fat diet for the obese, sedentary, smoking heart failure patient. I'm good with that. Do it. But OT, what are you doing to make sure that they can get in and get out and can prepare those meals? Are you working with them on those activities? Are you making sure that they're not so exhausted therapy by giving them an aerobic exercise program, PT and or OT, so they can do their ADLs without exhausting themselves, and they can get it to the end of the day and not have to throw a 3 gazillion gram salt hungry man meal in the microwave for dinner because they're so exhausted they can barely get through their day because they've worn themselves out, because they don't understand energy conservation. They don't understand pacing. They don't understand by pushing through all that, they're really making it harder on the central pump, and that they need to have stronger muscles in the periphery, right? So that they use the oxygen that an impaired heart, an impaired central pump can get out to the extremities like super unleaded gas versus regular unleaded gas. They don't understand that their own dyspnea is a sign that their heart is falling behind. Are we working with that and including that in those activities they have to do every day to remain safe and independent in their home? Vital signs, we're all taking them pre, post, during. We're getting a very clear picture on how this person is functioning. And monitored activity. What activity is essential for them? What is essential for recovery or optimizing their functioning within the acuity or the severity of that disease process? And nursing, don't run around the house for them. Reinforce their exercise programs. Have them move around the house with you. Right? Cindy's a big one to say, if you spend more time, if you leave the house of any visit, admission or otherwise, more tired than the patient, they probably didn't do a good job telling you, you did all the work, right? They didn't do too much. And so it was mostly an interview. Let's move them through the house. How do we monitor that activity? Do we need to put a home health aide in to help supervise and cue them about taking rest periods during the metabolically demanding activities of showering, bathing, dressing, personal hygiene? We all know this, but do our care plans look like this? Let's talk about that fluidity fluency of interdisciplinary documentation when we're talking about activity monitoring. Let's look at everything that's happening. The nurse is going to talk up to them about how activity is helpful, but too much can be bad, how the medications are going to interact or respond, or how they're going to be able to respond. You know, a lot of times cardiac meds suppress heart rate, which is the natural response to increasing activity is to increase the heart rate. We increase the stroke volume. And with a damaged heart, I don't see that happening, right? How diet is going to fit in, and hydration. PT modifying, setting up the program, teaching them how to monitor their own exertion. OT, reinforcing that, teaching them compensatory strategies during very metabolically demanding ADLs or IADLs. Home health aid, provide that support system if they can't do this on their own until we can get them optimized or back to doing it. And reinforce monitoring of themselves through these activities. That is what a very integrated care plan might look like. Okay, and we always have to remember that with a heart failure patient, one size does not fit all. And so, what is normal for that severity of that disease process? Is it normal for them to have marked limitation with any physical activity, like a class 3 moderate, or is it normal for them to basically have some to be comfortable at rest, and ordinary physical activity may make them tired, but really have to exert themselves to really start to feel dyspnea, and to explain the severity of that disease process and how those are symptoms that they need to be able to monitor to be accountable for their own disease process. Does everybody understand that? Extremely important. So there's one way with one population that we can help to circle around those big events, you know, or those big areas that we all need to be involved with heart failure, in the hopes of reducing rehospitalization, because that's a big area, right? Let's look at another one under the one beneficiary, one care plan. Let's look now at improving function. And you say, oh, nurses are checking out, therapists, they checked in. No, 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 no. Not true. Let's go right to a knowledge assessment. Let's just break this down. Which of the following factors do you think are integral to a patient-centered defensible documentation to improve function? Do you think it's A, the device assistance in increasing gait distances required for ambulation? B, the amount of assistance required for bathing and dressing themselves post-hospitalization? C, the balance and strength deficiencies and their impact on safe patient mobility in home? Or D, are all of those correct? Which one of those would stand up as the most patient-centered component that is defensible? And honestly, I'm going to tell you, like Cindy walked through, if you did not, you might have thought about C, balance and strength deficiencies. What is their impact on that patient's function in that unique environment? Okay, simply listing distance, device, and the fact that they're walking further means nothing. Simply putting that they need a certain amount of assistance now that they're home from the hospital doesn't mean that it requires you, right? And we've got bathing and dressing activities. And so that automatically eliminates D. But if you think about it from a very PT point of view, we have to always tie it to what it means to the patient. Okay? And so looking at the impact of pain, here's a great way to look at function. We capture this information, right, in M1242 on the OASIS, and we still want to focus and set our goals around the Wong-Baker FACES scale or the 0 to 10 pain scale. And in reality, don't we really want to know the impact of how that pain affects them? Have you considered using the functional pain scale, which I've listed here for you? Would this be a viable way? Because some patients are always going to have pain. Chronic pain is something. My mom is a terrible osteoarthritic. She's always going to have pain. The question is, can she manage that pain and function at the age of 78, almost 79? Okay? Or is she at the point where her pain stops her so much that she has become more sedentary, weaker, more prone to fall, and less able to take care of herself and live on her own? There's a big difference. People have pain. Pain is an individualized, very subjective report. How people manage it is different. What we want to know is the functional relevance and how it impacts their ability to do what they need to do every day. So it's important that we know what the functional issues are, but don't leave pain out of that equation, and consider incorporating the functional pain scale. And this is an objective measure, and you can resources it and look this up. Okay. Let's look at another one before I turn it back over to Cindy for one of her hot button topics of medication. Let's look at reducing falls. That's another thing we capture information on. And when we get to Oasis D, we're going to have to talk more and more about falls and interrupted falls, and we're going to have to qualify high or low risk. Here's what I'm going to say to you. Again, don't reinvent the wheel, right? We already do a multifactorial. But are we doing objective tests that look at it? Sure, we do our MAC-10, right? And its robustness in being able to differentiate between a true faller and not is not as strong as you'd like it to be, because they're looking at its balance, and falls are multifactorial. There's intrinsic factors like vision, responsive medications, as well as cognition and the environment. These things all factor in. But when we look at the falls risk assessment, however it is scored, and whatever objective measurements we use, such as the TUG or anything like that, why don't you score that first and then go about answering your M1800 items, your functional items? Because here's the idea. A person really can't be independent, which is many times a 0 or maybe a 1 in some with setup, right? With activities, with functional activities, if they're not safe. And a person can't be safe if they're a fall risk. So let me say that again. If you do your score for falls risk first and let that inform your scoring of the functional M items, and a person is a falls risk, they should not be independent on any of those measures. Think about it. Because independence assumes anytime, anywhere, anyhow, I won. Regardless of assistance, device, verbal cues, someone in the vicinity, right? Lighting, doesn't matter. Doesn't matter. It's independent is independent. That means I should never have to focus on it. I can do it. The question is, I have to ask you, is how many of your patients, when you first meet them at home, you would turn your back on? You would let them do anything. So yeah, go up and take that shower. I'll be down here writing my note. Heck, I got to run out to the car. Go ahead and let the dog out. Put him on the leash and walk him out back. Go ahead and take your medications. Oh, you don't know what you just got them yesterday, but go ahead and take them. I'll be right back in. We don't let them do anything, right? Because we have this concern about their safety. So independence assumes that a person is safe and able. And if a person is a fall risk, on that factor alone, regardless of cognition and all those other data items that we capture, they cannot be independent. So, Cindy, I'm going to turn it back over to you at this point so that you can bring us home and give us some time for the question and answer at the end. I hope we've tripped a lot of triggers here. Let you talk a little bit more about the thing that kind of puts a burr under your saddle is M2020, management of oral medications.
Thank you, Dee. And as a reminder, if you have additional questions at this point in time, you can go ahead and type those into the Q&A box. We don't want to miss any. Things that have popped up along the way we've incorporated into our current conversation, but we don't want to leave anybody with issues unheard. So as a reminder, please feel free to go ahead and use that box if you are so inclined. But Dee is right, and it seems kind of odd, also as a physical therapist, that this is an issue that just makes me crazy at times in relation to why do we keep recreating the wheel? Why do we keep developing new tools and all of this other thing to get ourselves where we need to be? And why do I say that? Well, item 2020, the medication management question, first of all, we have to understand that in order to be scored as a 0, a 1, or a 2, the patient has to be completely error-free. So they are taking the right medication at the right dose at the right time every time. There's not a single mistake. That is how you can pick a 0, 1, or 2. A 0, 1, or 2 represents the methodology that the patient is using, but all three responses are tied to perfection. If the patient is making an error lands you immediately to response 3. And response 3 talks about medications being administered by someone else. And we can get very bent out of shape and have for years about they live alone and there isn't anybody administering, and we, assume again that administration is, putting it directly into their body because we're all medical people. We forget that OASIS is a data collection tool and sometimes uses medical sounding words, but it's not a clinical instrument. It's simply collecting snapshot pieces of information about our patients. So we have to understand exactly what the question is expecting. So when we pick a 0, 1, or 2 at the start of care, and then create a plan heavily reliant on medication management issues from nursing, the question very correctly raised is why? If they already have a system in place that is foolproof, what are you lending to this situation? An error is an error. An error can be an outright, I forgot to take it and didn't take it. It can be, I got distracted watching Drew carry, and so, yeah, I was supposed to take it at 10 o'clock, but I took it at 2 in the afternoon. It is literally right med, right dose, right time. Consistency on that day of the assessment. So we see that the margin of error given our patient population at start of care in particular is pretty high. And the question has never said, always assume that the patient is correct and not having a problem. If you've identified issues with memory, if you have some concerns based on your skill and expertise about what's been going on, those are all valid. But how do I determine what does it really take to get your oral medications into your body? Well, do you need to know what to take? Obviously, you do. Do you need to know when to take it? Another obvious one. I know, it's late in the afternoon. You're like, what, she's pitching underhanded? Obviously, we know what those are. Okay, my third question. In order to take all of your medications correctly, do you need to know what the side effects are, what the risks are, what the possible duplications are? If you thought yes, well, first of all, you're probably a nurse. Love you to death. Actually, the answer is no. In order to get my medications into my body safely and consistently, I don't actually need to know the duplicates, side effects, interactions, or potential adverse reactions. That is all about the drug regimen review, and that has a whole separate OASIS question about your identification of clinically significant issues. But that does not apply here. If I tell you that I have a red pill that I take every day at 4 o'clock, and I take that red pill every day at 4 o'clock, I'm not making a mistake. I can tell you it's for my heart. I'm not even being very specific with you, but the red pill is the one I'm supposed to take at that dose at that time. There isn't an issue with how my oral medication is being administered based on the criteria of the question. But this raises a whole other issue in home health. I need to know what to take and when, but in order to take the medication correctly, do I have to be able to get at it? See, this is a factor not really considered heavily on the inpatient side because they bring the medications to the patient. You don't see people wandering up and down the hallway getting their medications out of the drug cabinet. You have people that bring the little pill in the little cup when it's time to take it. Or you have to ring your bell repeatedly because you know it's time to take it, but someone brings it. The home, you got to go get it. And now we're back to a multitude of things Dee has already touched on in relation to environmental issues, fall risk, balance, safety awareness. The home situation alone can present itself as a complication to effective oral medication management because patients can keep these things all over. We know exactly why we tell patients to collect all their medications in one spot before we come. I know it's a time-saving issue, but the reality is that's where they keep them. This deranged Easter egg hunt from hell as they wander all over the house trying to get their medication, I know takes time, but how are they doing that effectively so that they get the right medication at the right dose at the right time every time? A patient can tell you, I missed it because I was watching TV, or my back was acting up, so I took the pill a little bit later, or because my back was acting up, I took the pill sooner because I took it closer together to see if that would help. Those are all considered mistakes. So how we manage medication takes on a whole other level beyond the knowledge piece and factors into Dee's previous examples about the functional implications. As a physical therapist, why would I not include in part of my comprehensive gait assessment, where do you keep your medication? Where is it? Because if you failed the fall risk assessment and half the other tests I tried to give you, I don't really like how you're walking across the living room, but you're halfway decent as long as you hold on to that walker with both hands like I'm telling you. How are they getting their medication? Where is it? OT, we've heard for years about the fine motor skill involved with opening a pill bottle. I absolutely understand that. And I have yet to see it as a routine assessment item in home health as to their ability to open a bottle of medication. And combine PT and OT efforts, and let's throw speech in for cognition. How's the patient going to get the pill into their body? They've got to get to it. They've got to get it open. Now they've got to get some water to help get it into their body. So forget the walker. We don't have an octopus. They don't have enough hands to hold on to this. So we've got a glass of water in one hand, the pill in the other. Now we're going to put it in our mouth, throw our head back to get it down with the water. Oh, my gosh, on patients that have fall risk. This idea of comprehensive management of the patient, I think we have overcomplicated what that expectation is. We've fallen into old habits of, well, medication is nursing and fall risk is therapy. And if you fall in the bathroom, that's OT. PT handles it outside of that. OT, you deal with just stuff in the head. So it's the swallowing and, can they, communicate well and recite things, that not like memory has anything to do with medication, but you stay over there and do your thing. What we're trying to help us see is we are the ones who look at this and think it's way too hard. It's way too complicated. It's more work when it's actually less. And we are not suggesting you take every one of our examples and sit there and go, we've got to overhaul the whole way we plan care. Because you know what will happen with that? Nothing. It will be ragingly unsuccessful. It's changing too many things at the same time. I have seen people try this, and it just flops. And then we all go, see, those two nuts were crazy. You can't really do this. This is just throw our hands up, and this is not. Okay. The reason we provide you so many examples, whether it's the heart failure patient, medication management, the fall risk issue, is so that your organization can pick one of those or two of those and start with that. Success builds on success. It isn't about Dee and I sitting here saying people don't do care right. We've lacked focus. We've created requirement upon requirement and form upon form and layer upon layer to the point where we can't even see straight most days. We're just trying to get patients seen. How do we take something like medication management, much like the wheel you saw for dealing with heart failure, and say it is a multifaceted issue? We can be patient-specific when we pay attention. Does this patient issue of managing their medication, is it truly about understanding what to take and when? It could be, but have we looked at the full complexity? What about their mobility element, their manual dexterity, their cognition, their ability to access it, their aerobic capacity? I run out of gas in the afternoon, honey. I can barely get out of this chair. So how are you getting your medications since you live alone? And I know what a good portion of you were thinking. Move the pills. Ah, yes, absolutely, I agree with you. Do you know what that's called? Skilled care. Because if it was common sense to do those things, the patient and or their caregiver would have figured that out before you showed up. They don't. You recognize a situation, you provide intervention, you provide instruction because of what you recognize with this patient. As Dee said, I would agree, well over 90% of clinicians out doing home care are doing a great job for patients and a tremendous disservice to themselves by neglecting the detail, neglecting the focus. So again, we just provide enough information so if one of these resonate or you've had issues with your outcome specific to oral med management or increase in falls in the agency or concern about managing the GG items in OASIS D as more a focus on function and how that ties to fall risk, pick something because this is why we do patient care. We just want to think about making it simpler, making it more focused, making it cleaner. Without all the extra stuff somebody told you one time you had to put in it and make sure you write all this and you got to have this and you got to have the other, a recognition that it's healthy at times to really look at what we're doing and saying what is truly contributing to value and what isn't. What is not a requirement and why am I still filling this out? And not in I'm in a bad mood one day and decided half of what you told me to fill out is dumb. Not that, but in a coordinated agency effort to look at our documentation tools and say, are they helping us or are they making it harder? And how do we develop strategies to use them efficiently? Are we addressing subjective information. We've touched on this. We're not going to beat this to death. We need to look at it and say, does our subjective information show what the patient is interested in, what's working, what's not? Are we collecting meaningful objective information? I got to do 12 tests because somebody told me. No. Which ones make sense for this patient? And what am I providing to them from an educational and instructional standpoint? And not just verbalized understanding. I may have to come back more than once to ensure you actually understood it, that you follow through on it, that you're able to do it. It's not a compliance. I just come back and make sure you do what you're supposed to do to keep you out of the hospital. But do you understand our goal is for you to be able to manage these things when we're not here, so that ultimately you manage them indefinitely and avoid unpleasant events to the hospital and to the emergency department or feeling lousy by following what needs to be done to keep you in good shape. Our ability to analyze this information, that's where we shine. What did the patient tell you? What did you tell them? How do you know this was a good visit? How do you know? I think sometimes we've turned documentation and we only write about bad stuff. We only write about the limitations and the wrong and what they don't remember. But as we provide care on those routine visits, when they say, I did this or I tried that and it was great, or you notice that it's better than it was, that she's taking those medications out of the pill planner with you saying less. Maybe the first part of it you said nothing, which when you first started you had to say a whole bunch of stuff. That is measuring the impact of your care. And then ultimately, what's our plan? What's our plan? Plan for next visit is a great way to tee up, I know what needs to be done next. I'm going to say, assume that I got the winning power ticket and won that $1 billion this week, and I'm not making any more visits this week. Might not be making any visits for a while, but I know I'm not making any more visits this week when I win $1 billion. Could other people pick up your patient records and continue plans of care with the patient? Why is it when we're going to be on vacation, we got to leave 97 voicemails telling people exactly what they need to be doing for this specific patient? Why doesn't our note say it? Why can't we just, here's my chart. Go see the patient. Yeah, there's always that nuanced piece about the daughter's kind of crazy and the one-eyed cat might spit at you that we don't necessarily put directly in the note. I get it. But when we feel the need to verbally explain all of this before we're going to step away because nobody would be able to pick it up from the documentation, those are cues that we need to reevaluate. And keeping it simple is our mantra. Getting our head engaged. Not in a passive, just tell me what to write then, but I know why I see this patient. All this other stuff is fluff. Why am I here? What do I need to do? What are we going to do next? How is this beneficial to the patient? What does the patient want to get out of this? Those are the questions we're trying to answer. Those are the things we have to really get behind and deliver on in our documentation. So we know there's a lot to chew on. I'm not seeing any additional activity in the Q&A box, but that sometimes means people need to chew on it a little bit. I'll share a few closing thoughts here to give any last-minute people their opportunity to put some thoughts in if they want. We look forward to next week, our final installment of this 3-part webinar series. You may say, oh my gosh, why did it take 3? Old habits die hard. And we are literally trying to re-energize our industry, our disciplines, our individual clinicians to own this. Because we have to understand in the next couple of years, we are slated to have a pretty substantial overhaul to the payment methodology to home health that will change how patients are measured, how we look at this, how we manage them. We need to get ahead of that. We have the skill sets. We have the right players. We have the right pieces of the puzzle. But we've got to get them to start to line up so that no one can come in, take our charts and say, I'm not paying you for this. No one has to sit in those meetings with CMS listening to this long mantra about how we're seeing patients that don't need to be seen. There's all this fraud and abuse in home care. These people are just trying to make money. It's horrible. And to see one more article of somebody who, goes to jail for $1 billion fine because of all the stuff that, okay, there are bad apples, but the majority of us are truly trying to do the right thing. The scrutiny level is not going to go away. We have to create content that gets them to move on to somebody else, to go find the real bad apples, not the people that can say, listen, we do care, we just document poorly. We can't afford to leave that on the table, to leave ourselves at risk, or to continue to exacerbate risk by just saying, whatever, it's just documentation. It will determine our future and the future that's way beyond that as well. So, thank you very much for your time today. You have both my email address and Dee's if you prefer to ask your question outside of this particular training and have some thoughts you'd like to share. We welcome that. And again, we look forward to regrouping with you for the third session. And we hope that you have a great rest of your week.